We're all passionate about what we're talking about. So I'm really glad to have you guys here because I see the work you do or I've heard the work you've done. So I'm really excited for us to have this conversation. So if you can each just introduce yourselves and tell us what sparked your interest in infection prevention and any AMR related work that you're currently doing.
Okay, I'll go ahead and start. So my name's Terry Hewlett. I am an infection preventionist. My background is nursing. I started in 79, so I've been doing it for a while. The majority of my nursing was in neonatal ICU, and we had at one point several different outbreaks. One was Pseudomonas and one was Stenotrophomonas. And in working with the infection preventionists it was a large academic medical center, I became aware of what infection prevention was and why it was important. Once we got the outbreaks controlled, the IPs recruited me to join their department. And I spent another 5 or 6 years working in the acute care setting, realizing that infection prevention wasn't just in acute care. There was an opportunity for me to take a position with the State Hospital Association as their infection preventionist, working across the state. So learning the challenges of rural facilities and critical access hospitals. And that was where I got my taste for antimicrobial stewardship, antibiotic stewardship. Probably one of the big things we did in the 3 years that I was there was to lead a statewide antibiotic stewardship collaborative. And we had 27 hospitals of all shapes and forms that worked with us over those 2 years. And because it was a hospital association and their members were acute care facilities, I learned real quick that we couldn't do any work with long-term care settings. A lot of the rural facilities had long-term care units in their hospital or long-term care facilities on their campus. And being told that I couldn't work with a group of people that would directly impact the acute care setting drove me to leave the hospital association, go into independent consulting so that I could work with anybody across all settings and not have to worry about who was going to tell me no. The 2 year antibiotic stewardship collaborative really opened my eyes to the antibiotic stewardship world, and that was kind of my jumping point.
I totally understand how it feels when you're limited, especially in infection prevention, and you have a passion for everything else. You don't have to focus just on acute care. So, what about you, Troy? What sparked your interest in AMR surveillance and all the research you're doing?
Well, thanks, Carol, once again. And I think my story is going to be a little bit different. My name is Troy Score. I'm an associate professor at the University of Wisconsin-Milwaukee in the School of Biomedical Science and Healthcare Administration. Well, I've been working on performing research for about 30 years. And so originally, when I was an undergraduate at the University of Wisconsin-Madison, I had the opportunity under Dr. Bill Widens to really understand the host pathogen interaction working with malaria. And that really started my passion for just understanding infectious disease and prevention as well. And so my doctoral work was in Texas A&M with Dr. David McMurray, starting basically working on development of new tuberculosis vaccines. So I got this awakening of how amazing these pathogens were, of just outwitting the host many times. And then I proceeded to Children's Hospital in Oakland, California, working with chlamydia, both the sexually transmitted as well as the ocular infections. And then I had a serendipitous moment. So I started a new job as a professor, and one of my colleagues was an avid fisherman, and he brought me a white perch with an ulcerating lesion on the side of it. You didn't think that was coming, did you, right? And he brought it to my office one day and he said, "Hey, you should figure out what caused this infection." It's like, I blew it off at first. And then I was like, kind of sounds like a fun project. So we went about, figured out what it was. And it was this bacteria called Aeromonas, which I was not that familiar with. And so one question led to another. And so I asked, like, whoa, how common is this bacteria in the water? So I started studying the presence of Aeromonas in some of the Great Lakes. Then I started asking what was the level of antimicrobial resistance. I found it to be quite high in particularly Lake Erie and against some of the current antibiotics used to treat it. And then I just kept asking the next question, like, where did these resistant strains come from? So then I started studying wastewater. Then I obviously I've been doing wastewater for a while to really understand its impact on clinical resistant trends. And then I'm continuing my work now where I continue to ask questions with wastewater. I started going to the environments, so in the surface water, the beaches. I'm working with clinical strains to see how they're evolving. And then now I'm looking at food too. So I'm really trying to do the whole One Health perspective. And I think every year I'm just fascinated about just this quick evolution of antimicrobial resistance.
Yes, the One Health perspective, that's really what we need to start looking at, especially with infection prevention. We just focused on the humans, but especially for us who've worked with public health, we get that perspective that everything is interconnected. It's not just humans. Let's look at animals. Let's look at agriculture. So
Right.
I like that you're doing this work. GV, can you introduce yourself for us?
Yeah, thanks, Carol, and thanks for inviting me to this great platform. So, I'm Mr. Jibi, a senior specialist and lead infection control, and I got a strong focus on antimicrobial resistance and stewardship. So, I got 14 years of experience in infection prevention and control. I've been working across 4 different countries. My journey in infection control began in 2009. I was driven deep by an interest in microbiology and its critical role in healthcare. So I found myself drawn to understanding, how microorganisms behave, spread, and impact patient outcomes. So over these years, this passion has been grown, and particularly I was witnessed firsthand how effective infection prevention measures can transform, healthcare settings and save life, and it can bring forth a positive outcome to the patient, especially in the hospital settings. We focused on antimicrobial resistance and stewardship. It took center stage during the post-COVID era. So the widespread and often inappropriate use of antibiotics during the pandemic, it underscores the urgent need for an robust antimicrobial stewardship programs across the world, because mainly a lot of antibiotic has been misused, especially the URT antibiotics like azithromycin and amoxicillin. It has been widely misused around the world. So this global challenge, motivated me to delve deeper into AMR and recognizing its profound implications for, this patient safety, public health, and all. So in my current role, I'm dedicated to implementing the evidence-based strategies, educating healthcare teams related to antimicrobial resistance and stewardship program, guiding them, leading them, collaborating internationally to combat the twin threats of like healthcare-associated infections and antimicrobial resistance.
Well, thank you all. At least we share a passion about infectious diseases. So that's amazing. So, Troy, with the work that you're doing, what do you think is a big challenge in combating antimicrobial resistance in community settings, especially?
Yeah, great question. Within the community here, I think it's a little bit challenging on multiple fronts. I mean, we're looking at they really try to see how wastewater and the environment and agriculture are all connected to the clinic is, I think, one of those struggles of how do we bring them all together and study them. And that's why I think a lot of our research trying to analyze everything within the same city is one of the ways how we can do it. But I think really the bigger challenge is really just the global perspective, because I know a lot of our research, which I'll hopefully be sharing with you in a little bit, really stresses that there's an inverse correlation with a nation's gross domestic product of income and antimicrobial resistance. That these poorer countries are the ones that are having the biggest resistant rates. And so I really think that's one of the biggest struggles that we have, is how do we as a world come together and really help each other out in this universal fight.
And in your opinion, is there anything that you've discovered that's driving the increased rate in lower income countries compared to more developed ones?
It's hard to prove one way or the other, and that's one of the biggest struggles with the literature, is that it's hard to point what's the causative. But we've identified a lot of associations, and like I said, I'll share you a little later. But one of the things that I believe is one of the driving factors is wastewater treatment. And it's kind of weird that we're talking about wastewater-based epidemiology is a great way to try to monitor the antimicrobial trends. However, we've shown that antimicrobial resistance is higher in untreated wastewater than treated wastewater. And so We also show that countries who have lower environmental policies, so in other words, they've given them an EPI score based upon how environmentally friendly each country's policies are and their infrastructures. And it's once again, it's inversely proportional. So the lower the environmental impacts of their policies or the infrastructure, in other words, they don't have wastewater treatment, then the higher levels of antimicrobial resistance. And so to me, they just kind of all just yell the same thing. Like, we really need to step in and help if we're going to really try to reduce the growth of antimicrobial resistance and spread.
Yeah, from a logical standpoint, it makes sense to me from that environmental aspect. What about you, GB? What challenges have you seen in the work that you do that's causing the challenges in reducing antimicrobial resistance?
So in my opinion, the most critical challenge in combating the AMR today is the widespread misuse and overuse of antibiotics, especially in the healthcare as well as in the community setting. So this issue is actually compounded by the lack of awareness among both the healthcare professionals as well as the general public about the consequence of inappropriate antibiotic use. So if you see in the healthcare settings, ensuring adherence to the antimicrobial stewardship program, it's actually a persistent challenge. It's not even in the specific countries, all over the world, in healthcare settings, ensuring adherence, now it's actually a persistent challenge. Many clinicians face pressure to prescribe antibiotics even when they are not strictly necessary. It's mainly due to the diagnostic uncertainty they have or because of the patient expectations. And furthermore, if you add inadequate infection prevention measures such as poor hand hygiene, improper disinfection practices, then it also facilitates the spread of the resistant microorganisms. And if you see in the community settings, the availability of the over-the-counter antibiotics and self-medication, and often without any proper guidance, exacerbate the problems. So there's also a critical gap in education as many individuals, remain unaware of the dangers which is posed by the AMR and also the importance of completing a prescribed course of antibiotics. So this in community settings, the main thing is the over-counter, availability of antibiotics, and also, in the entire world, people are turned to be as doctors themselves. Those who have a limited knowledge related to medical field, they treat themselves actually. And if I see in the last 2-3 years, which I found and which I understood through the research, like 27 to 28% of people are using antibiotics without even prescribing from the doctor or without even consulting from the doctor. So lastly, the slow development of new antibiotics and a lack of investment in socioeconomic countries in alternative treatments, which also led to the urgencies about AMR. And without any collective actions or without proper spanning education, policy enforcement, innovation, this fight against antimicrobial stewardship, it remains a significant challenge across the world.
Yeah, it makes sense with the health illiteracy all over the world and also resistance to what the professionals say, and we're seeing becoming more and more of a problem, especially after the pandemic. And it's all over the place, as you said. Terry, what in your opinion is causing this issue?
I'm going to be short and sweet. I think both Troy and GB were a little more global. Troy specifically in terms of wastewater and environment stuff. For me, thinking boots on the ground, working with those directly at the bedside who can impact, following up with the diagnostic stewardship piece that GB talked about. Diagnostic stewardship for me is huge. And I still find that on a daily basis that providers who aren't well educated on antimicrobial stewardship and antibiotic resistance are ordering just pan orders. Part of an admission order set at one of the facilities I'm working with is a UA with a reflex to culture on everybody. And we're getting these positive UAs that then they prescribe antibiotics. And so for me, the big challenge is driving that piece. I think if I can make headway in getting proper diagnostic stewardship in place, I think that can impact everything else from antibiotic orders to hopefully impacting resistance. If we're not using antibiotics and we're not treating asymptomatic infections, that's where I see my impact. I think about places like dentist offices that want to prescribe antibiotics without guidance. And when I take the guidance to them and they give me pushback about why they want to order it, they can't justify why they want to order the antibiotic, just that to them it makes sense. So those are my two challenges with moving forward and down the road, hoping to have impact on antimicrobial resistance, but starting with the nuts and bolts of the bedside.
Got it. Yeah. So it's not just the patients, it's the environment, the professional as well. Everyone's involved with
Correct.
causing this problem.
Correct.
So Troy, based on your current research, what would you say is contributing in supporting infection prevention efforts when it comes to wastewater surveillance and antimicrobial resistance?
Yeah. So before I start, sort of, so GB and Terriers I totally agree with what you were saying on those. And I just at least got back from Uganda over the summer, and it was, yeah, there's a huge problem with the overprescribing of antibiotics. Just not even prescribing it, you just walk on in and get it. And so I have to say, I know most of my research is on a lot of it is on wastewater and how they correlate into the clinic. And I'm going to just briefly touch on the fact that a lot of our work it works with like E. coli isolates as well as Aeromonas, and we have identified that wastewater isolates look very similar to clinical. So, and if you look at virulence properties, like their ability to potentially cause human disease that are coming out of literally treated wastewater, they look very similar to what we see in the clinic, just further confirming this could be a public health concern. What I do want to spend a little bit of time, if I could, is one of the things when you're doing this research, there's so many publications on antimicrobial resistance that the scientists, you're reading it, trying to understand, like, how do I take everything in to really make an overall conclusion? And during COVID, I had a lot of time, since we couldn't be in the lab, to really dwell on that and try to figure out how can we do that. And so I set out to do a systematic review and meta-analysis where we literally took data on, I'm going to use Aeromonas as an indicator species because in our paper, we compare it to E. coli to show that they're all found in similar environments. And Aeromonas causes gastroenteritis, it causes wound infections. It's not as well studied in the United States, but in other countries, especially Southeast Asia and all that, it is quite common. Anyways, and so what we did was we looked at a 20-year period and we pulled all of the articles on Aeromonas and we pulled all of the data, all the antimicrobial resistance data on every isolate. So we basically got data from 15,000 isolates from 221 articles from around the world. And we analyzed antimicrobial resistance against 21 common antimicrobials from all sectors. So we looked at the clinical, we looked at wastewater, treated, untreated. We looked at surface water from lakes and from rivers. We looked at vegetables. We looked at meats, anywhere from goats to cows. We looked at fish, from wild fish to aquaculture, basically farm raised, and said, hey, are these drivers of antimicrobial resistance? And we have all of this data. And then we start to ask the question of, does antimicrobial stewardship, do some of the ideas that the World Health Organization suggested, their goals, did they actually have an impact on antimicrobial resistance? And so we basically wrote a book on this. I can only share a few things with you, I think, for the sake of time and being kind to GB and Terry, so I apologize ahead of time. But one of the really cool things that we found was that of the 21 common antimicrobials, when you look at all sectors, so the environment, agriculture, and the clinic and wastewater, you see there's no difference in resistance across the board. Nothing statistically significant, except two antibiotics and only between the clinic and wastewater. We see amongst the fourth generation cephalosporin, cefepime, as well as Trianam, which is actually a last resort antibiotic, that wastewater had 6 to 8 times higher levels of resistance than clinical levels. And to me, this further suggests that if we look at the wastewater for its story, it may be foretelling that in the clinic, we're going to be seeing these levels rise. And overall, we see resistance levels rise as well. And once again, the numbers are pretty straightforward, but to see some of the most common, the most recently used antimicrobials and seeing them high in the resistance levels higher in wastewater suggests that this wastewater-based epidemiology may be a good idea. One other thing I want to talk about was that the World Health Organization in order to address the antimicrobial stewardship, they came out with categorizing antibiotics into 3 categories, right? It was the AWARE program, the access, the watch, and the reserve antibiotics. And the idea was that the World Health Organization said, I think every country should set a goal where 60% of all of their antimicrobials that are prescribed for community health and everything else is in the access or the narrow spectrum antibiotics, right? Especially for the first and the second choice against common pathogens. And so we looked at all the data and we're like, how can I see that actually works? And so what I did is I took every country's antibiotics that were prescribed under access compared to watch, and we took a ratio of it. So they call it the access to watch ratio. So you want a higher number, suggesting that you're following, you're prescribing more access than watch. And then I looked at it again 15 years later from the same country. And if that changed and they started using less access drugs and more watch drugs, we then compared all of that trend with the current antimicrobial resistance levels from their countries. And what we saw was the World Health Organization was on target, that the countries that over a 15 years trend, if they started to use more of the watch drugs and less of the access drugs, their antimicrobial resistant levels were actually higher. And which, once again, it's one of the challenges that we have in science is that it's hard enough to come up with the goals. I mean, right now, the World Health Organization just put together over 200 experts in the field trying to draw together what are the top 40 things that they can implement policies that actually will make a change. Extremely challenging. But then the other challenge is how do we actually prove that it actually is working, right? And so I think that was one of our really big findings. And then the other thing was that, once again, I told you about the issue that when we look at the nation's gross domestic product or income, it was inversely proportional to the resistant levels that we see. So the poorer the countries, the higher levels of resistance. That was also seen amongst environmental protection industries, which were the environmental performance indicators included categories like climate change and wastewater treatment, water management, air quality, all of those things. And once again, we see an inverse correlation. And so I think really it just really speaks very loudly that if we're going to combat antimicrobial resistance, especially with how easy it is to travel nowadays internationally, we really need to invest in poorer countries' economies and make sure that we can help them with their infrastructure and help them write policies to really implement them and make a difference.
So if I hear you correctly, we are just at the beginning. We haven't even made any strides or any improvement in the work that we're doing against antimicrobial resistance.
Well, I mean, if you're a country that actually is prescribing more access drugs, then actually you are fighting it, right? But once again, I think if you're going to win this fight, you have to make sure that you're looking at it from a globalist perspective and not only looking at your own country.
Yes. Terry, I have a different question for you. Or did you want to follow up on what Troy just said?
Okay. No, I'm just in awe listening to Troy.
I know. The first time I talked to him, I said, everyone needs to know what
I could spend all day.
So Terry, I had an opportunity to look at your website and the work that you do. So I see that it involves a lot of antimicrobial stewardship for infection prevention. What would you say are the challenges that healthcare facilities are facing in implementing antimicrobial stewardship correctly?
I think there's a few, and I think we've touched on it briefly. Kind of the one big thing for me, and again, going back to a lot of those facilities, whether it's long-term care or acute care, the facilities that need my help are the smaller ones that don't have tons of resources. And so one of the big challenges that I see in the settings that I work with, in the critical access and rural facilities, is having access to physician expertise. I can come in and give them guidelines and share core elements and give them ideas of how to put things in place. But when it comes to identifying or deciding if something is a contaminant and they don't need to treat versus a true infection that they need to treat, what they need to treat it with, I'm not their expert. And so helping them find that expertise has been a challenge. So that's the physician piece that I see. Um, I think the second piece is in educating and driving the collaborative work between infection prevention and the bedside caregivers. And so when I say that, helping those at the bedside understand what their role is in infection prevention, but in antibiotic stewardship. What I discovered as I started working with them is nurses, we weren't ever taught how to read a sensitivity report. We weren't taught the specifics of making sure that the cultures that you get to the lab in a specified amount of time. And if that urine culture sits at room temperature for 4 hours because nobody has time to take it, how that can impact the results that you get. So it's just been helping the nurses understand their role in infection prevention, antibiotic stewardship, and the outcomes that we see with their patients. And I think for me, the other piece is just and they all tie in together, but helping them understand that knowing what antibiotic they're given, why they're giving it, the time period that should be written down. So going back to those core elements. And then what I discovered as an infection preventionist and realizing that not all infection preventionists are nurses. So another big challenge with that 2-year collaborative that we did in Colorado was as we would go out and work with IPs, they would say, that's not my job. It's not my job to educate on in antibiotic stewardship. I'm not giving the meds. And they would list why. There are some good articles that have come out by Dr. Rita Olens and Elizabeth Menzies over the last handful of years that really show that collaboration and how we can make improvements if everybody understands their role in the work. It's not just me as the IP, and it's not just the bedside nurse. It's not just the lab. Making sure that culture orders are ordered appropriately, that there's an indication, helping them understand what the indication is and where, if they don't know, where to find that indication. Teaching them that they can call me as the IP. If they have questions and they aren't sure, I make myself available to the facilities that I work with 7 days a week, 24 hours a day. They can reach out. When I was in the hospital, it was the same thing. Even though I was a Monday through Friday, 8 to 5, the units that I worked with that were my primary units knew that they could reach out to me on a weekend or on a holiday. And 99% of the time I would get back to them. And I think that helped me build relationships and build trust and made them want to step their game up a little bit.
That's amazing. And one thing I do hear is that we still have a fragmented system, especially with antimicrobial stewardship. And that goes back to what Troy said. The problem is global. It's not just in lower income countries. Even in the US, we have this issue.
Correct.
Yeah. So GB, I see that you've been working in multiple settings. You're currently in the UAE and you've been in other countries and you go between, if I understand correctly, between UAE and the UK. So what strategies have you implemented in limited resource settings as far as AMR is concerned that you believe can be implemented in other settings to make sure that there's progress made?
Well, that's a nice question. So before I'll answer this question, let me add one point, just an insight what Mr. Troy was been mentioning about. It's the attitude of the physicians, especially surgeons, in prescribing this justifiable antibiotics or the reserved antibiotics. So whenever we used to speak to the surgeons regarding some justification about why they prescribed about this reserved antibiotics, they would be, I'm well experienced about this one. I have 25 years, 30 years of experience, and you yourself, how dare you will question me in this regard? But doctor, somehow you need to justify why you're prescribing colistin. For example, they are prescribing colistin, polymyxin, tetracycline, and all. There is no justification. Even after surgery, their main intention and aim just to prevent infections. Even whatever happens to the patient, resistance, they never care about. Actually, when Troy was speaking, I was really thinking about my past experience in different healthcare settings related to this one. And so back to the question. So in my experience from different countries and also including the limited settings, I always believe that the key to the strengthening antimicrobial stewardship, it always lies in adaptability and innovation. So without this adaptability and innovation, we cannot strengthen our AMR programs or stewardship, even in the limited settings. So in these type of environments, what I feel is a most effective strategy which I implemented is leveraging the basic diagnostic tool like rapid diagnostic test. It always guide antibiotic use when advanced labs are not available. And moreover, this prevents the overuse of especially the broad spectrum antibiotics, which is often a heavy challenge in such settings. And moreover, I have focused on heavily on education training, healthcare workers to understand the nuances of AMR, empowering them to become stewards within their facilities. But up to one extent, this has been, successful. But there are still challenges when education training. Always, it's have a attitude problems and different other challenges in understanding, taking part in antimicrobial stewardship, as Ms. Trey has mentioned about it. So in many cases, we introduced simple but yet some impactful practices such as manual antibiotic timeouts, then prompting all the clinicians to reassess their prescriptions at like around 3 to 4 days or a minimum of 72 hours to optimize the treatment. And beyond the healthcare settings, if you see in the community engagement and all, it already tailored the awareness campaigns that is more critical here, in especially in the community settings, and particularly in reducing the self-medication and over-the-counter antibiotic misuse. So even something as basic as prompting made alcohol-based hand rub, following proper infection control measures, it all had a significant impact on infection prevention and indirectly, reducing the antibiotic demand as well as reducing the spread of resistant microbes. So what I have learned is that resource constraints should never limit innovation, that it should never interfere with our innovations, thoughts, ideas, adaptabilities, and by sharing this practical and moreover a cost-effective strategies, I found that healthcare facilities everywhere can adapt and strengthen their antimicrobial stewardship programs. This is what I gained out from my experience.
Wonderful. I like all the perspectives I'm hearing from different settings. This is really amazing. And GB, when you mentioned leveraging rapid testing, were you referring to PCR as opposed to cultural? For
It's actually I refer to PCRs mainly, and
Okay.
Sometimes we used to go for cultural source.
Okay.
But it's actually there are laboratories with limited settings, testing of antibiotics with MIC values, identifying of the species. There are some challenges out, but mostly stick on to PCR. Yeah.
Thank you.
Just to comment on that, GB is a good point, and I think that the future of diagnostic techniques is really advancing. I know right now we're working on like a point of care test where you can actually detect it right at the bedside. So I think we're going to be there soon. So I think you're right, and hopefully that the diagnostic testing can be of an affordable cost. Hopefully that will really help the physicians make the right choice and the nurses.
Exactly.
Cost is huge.
Yes, I like that you jumped ahead with that question. So what would you say that new technologies like genetic sequencing or AI-based testing, how do you think they will help with combating AMR in the future?
Yes, this is on me. I think it's going to be extremely exciting. From a teaching perspective, I'm a little worried, but from a research perspective, I am excited. So we currently have a grant right now. We've got a lot of wastewater samples dating back like 10 years ago. And so what we can do is actually pull out the antimicrobial patterns that have been existed for over 10 years and see if it actually foretold what's coming up and what currently exists now. And so I think that that's really where we're going. And I think that with AI writing these algorithms, we can literally predict the mutation rates and when we would expect to see a new gene almost appealing. I believe that's the case. I think also one of the things that is really exciting is the cheap price of whole genome sequencing. I just want to share with you, for instance, we just came out with a publication recently that we've identified the first ever clinical isolates of Aeromonas that carried ESBL, or extended spectrum beta lactamase, known as an SFO1. Most people are not aware of SFO1. It caused an epidemic a little bit out in Asia for a bit, about 10 years ago, and it's just uncommon. And so no one would have caught this because qPCR and PCR, we're looking for the most common ones, like the CTXMs, the TEMs, the OXAs, the KPCs. But if there's anything new, would our techniques catch it? And so by doing whole genome sequencing, we're able to identify it. And not only that, so by doing the short and long-term reads, we can put together the plasmid. So basically to see how it was, hypothesize how it evolved. And what we saw is that it's evidence to support that there's this crosstalk between bacteria who are non-enterobacteriales and enterobacteriales. And if you look at where the strains came from that were like Klebsiella and Enterobacters, they were in the clinic and wastewater, even in the United States, but they never made it into an Aeromonas at all throughout the world. And now we've just found it in Milwaukee. So I think it's extremely exciting because now we can go back to the wastewater and ask that same question, like, hey, is SFO1 there? Was it there in the past? Are we only seeing it for the first time? And that's a very specific question, but I mean, these are the questions that a scientist who are in the labs can keep asking. And then obviously, GB and Terry, you have more of the input as to clinically wise, what are the problems that we're experiencing there? But just from the lab perspective, I think it's a really exciting time.
I think that genomic epidemiologists will be very fascinated when this happens. They're all very excited already with all the advancements that AI is doing right now. So for all three of you, what would you recommend as a change in policy or guidelines to make sure that we can at least make a first step in the progress towards combating AMR? Let's start with Terry.
Oh, I knew you were going to say that. I'm going to go back to my focus with boots on the ground. I still think for me to have impact and to feel like I've been able to do any good with AMR, I need to help people understand why doing the right thing is the right thing and what the right thing is. From following the core elements to preventing infections. You know, when I go out and I have the opportunity to teach and present, if we can prevent infections, we're not using antibiotics. And if we're not using antibiotics, we're not going to be driving resistance. So for me, it goes back to that step one, prevent the infections. And if we can't prevent the infections, if we suspect something, appropriate diagnostics. Following all those things that we've already put in place, I don't know that there's anything that I would say from my perspective to add, because we haven't gotten really good at the guidelines that are already there. And I think if I can't get them to follow these now, I don't know how well I'm going to get anybody to follow anything new unless there is immediate impact for them. So if something new comes out that's going to eliminate the workload for them, then I can see that being beneficial.
That's a great perspective. I agree with that. What about you, GB? What kind of policies or guidelines do you think should be implemented to help us make a progress with combating AMR?
So as Ms. Cherry has mentioned, I do agree with what she was been telling about. So if I could recommend, something, big change to the current infection control policies related with AMR, it would be the, mandatory integration of antimicrobial stewardship program into infection prevention and control guidelines. And it should be applicable to all the healthcare settings. Currently, what I found is, infection prevention is a different branch where AMR stands for the different branch. So in infection prevention, almost like nurses have been involved, and whereas AMR, mainly the doctors have been involved. So if this AMR has been integrated with, infection prevention and control, that would be one of my greatest recommendation. And while AMS is not often, implemented in larger hospitals, it frequently is overlooked in smaller healthcare facilities and in community settings where antibiotic misuse is rampant. And when we embed this AMS into IPC policies, we can ensure that every healthcare facility, regardless of the size or the resources, they can actively monitor and optimize their antibiotic usage, especially with the clinical side. So this integration, what I feel, will involve in the routine antibiotic audits, real-time feedback to the prescribers, those who prescribe the antibiotics. Then we have got an establishment of a clear evidence-based prescribing guidelines. especially with the antibiograms. And additionally, these policies even can mandate, ongoing education for healthcare workers on AMR, and also it focus on the importance of stewardship programs across the healthcare facilities. And when IPC and antimicrobial stewardship team work hand in hand, we not only prevent the infections, but also we can minimize the inappropriate use of antibiotics. We can tackle the AMR from both ends, from the nursing perspective as well as from the physician perspective. So this change could significantly, I believe, that it can enhance our ability to control the resistance, and moreover, it can protect the efficiency of the current treatments, and also it will help for the future generations.
Yes, we've been very good at working in silos, and now we all realize we need to work together to make things happen. Troy, what are your thoughts?
No, I agree with what Terry and GB both said. I would just add, I think that, and this could be my perspective on this, is that I think the topic of AMR is sometimes a little overwhelming, and that when you try to convince people involved in healthcare that really if we reduce antimicrobial prescriptions or prescribe the right ones, more of the access over watch, that really would make a difference. And I think sometimes when you think about it, it's so overwhelming that you just feel like your little whatever you do is not going to make a difference. And so I think what I think was really needed is actually if we can take these cities or small areas that really implements strict antimicrobial stewardship policies, and then look at that wastewater, and theoretically that should be showing it. And I know they've done some of this in Europe where they've actually shown, especially in agriculture, where they reduce the use of antibiotics in animals, and you see that the resistance levels coming out of animals goes down. And I think if we can actually show that in the clinic, then I think we'll build up a bigger following of healthcare people believing that these policies might actually change it.
Wonderful. This is such a fascinating topic that we could talk all day, because I love all the perspectives that you bring. As we observe US Antibiotic Awareness Week and World AMR Awareness Week, what is one key message you each want to share with everyone for responsible antibiotic and antifungal use, just antimicrobial use in general?
Yeah, I keep going back to just the core. For antimicrobial resistance, what I would like those who are taking advantage of the offerings during Antimicrobial Awareness Week is to understand doing the basics will have huge impact. If we can get people to understand diagnostic stewardship, I think that's a huge piece that really hasn't taken off yet. People don't understand what it is, how to do it. And for those physicians who are still ordering UAs for every patient that comes into the ED, or for every patient that's admitted to a long-term care facility, we could have huge impact in the antibiotics that we're using and the antimicrobials that we're using, which downstream effect, to take a word from Troy, if we can start upstream, what we see downstream is going to be improved.
What about you, GB?
So if you ask me about the message which people will take regarding the responsible antibiotic and antifungal, this AMR awareness week related to antibiotics and antifungals, these are precious tools that should be used, very wisely and only when necessary. This is what one of the message which I should. Overusing or misusing, especially these antifungals or antibiotics, whether in healthcare or at home, contribute directly to the development of antimicrobial resistance. And it makes infections, more harder to treat. And even it will put everyone, including the public or the patients or the family members, wherever it may be, the hospital or in the healthcare settings, or even in the public or the community, always at risk. And it's crucial, for both individuals, healthcare providers, to understand that antibiotics should not be used for viral infections like, common cold or flu. Because this is, a misconception that whenever people have got common cold, even influenza, they start to use antibiotics for URT. And they know maybe sometimes that antibiotics won't usually work against like viral infections, but still that practice what they earn from their peer groups or from the previous experiences, they start to use. And that is one of the biggest challenge which causes resistance after the COVID era. People are blindly using antibiotics for COVID virus. So this common cold or flu and even antifungals, it should only be prescribed, based on clear diagnosis. Simply, antifungals should not be given to, people with mild amount of fungal infections, or even with, candida in the urine. It may be a colonized formation, and even not justification for an infection to take even antifungal drugs. And responsible use alongside, proper infection prevention practices like hand hygiene, vaccination practice is essential, in preserving the effectiveness of these life-saving treatments, and moreover for, create an impact and awareness for the upcoming generations.
Thank you both. Okay, Troy.
I think there's another thing, but it's just the fact that these microorganisms, we constantly keep trying to kill them with antibiotics, whether they were synthetically derived, semi-synthetically, or natural, and they keep evolving. So I think just that alone is just, before we scare everyone, it's fascinating, right? It's fascinating how fast they're evolving and just how wise they are, in a sense, to survive in their extreme environment. I think that Terry and GB did a good job of the healthcare, so I'm going to talk about the everyday person here, right? And that is, I think with chronic diseases increasing, with medicine constantly evolving, more and more people seem to be, at least they think they know more about medicine. And they usually, I hear a lot from physicians that sometimes they're the ones that are pushing the antibiotics. It's a business deal in a sense. They're going in there, they're paying money, they want something to come out. And I think we really need to teach everybody that, why don't you ask the physician, is this most likely a viral infection or is it a bacterial infection? Most of the time it's a viral infection. So the whole point of an antibiotic. Then maybe if your doctor prescribes you an antibiotic, or your healthcare professional, then maybe you should ask the question like, is this narrow spectrum? Is it broad spectrum? Like maybe asking just more questions and being more interested in learning more about it would really help to break down some of the struggles that I think the healthcare professionals are dealing with. And then also helping to empower just overall. We're all getting infections. We don't want to go into their unknown. We want to be more familiar with what we're taking, how it could also damage our bodies. How many people end up with diarrhea or severe infections or chronic infections as a result of that, right? Talked about C. diff, like how often is that when you go on an antibiotic and it can ruin the rest of your life? And you took it one time and maybe you took it for a viral infection. So you're never going to be able to get that back. So I think just really awakening it. And then also I really believe that we should open our eyes to other alternative treatments that are starting to come about. I work with photodynamic therapy using light treatment with chemicals. I think the pharmaceutical industry has really got their hand in and making sure we don't look beyond it. But I think the human population is brilliant, and I really think that we should keep our mind open to other alternatives to trying to combat some of these multi-drug resistant strains, to maybe relieve a little bit of the stress from them, and hopefully provide more ample opportunities for complete treatment.
Thank you all. This was amazing. I'm so fascinated by not only the impact you've already made in your different field, but also all the breadth of knowledge and insight you just shared. So thank you for giving your time today to discuss with me.